gynecologist of BRC, and he's adored by his patients, and I think you will love him too.
A very good afternoon to all of you, respected delegates, dignitaries on the dais and off the dais, and my dear friends. I must congratulate Dr. Patro and his team for organizing this pretty cool conference, which is a multidisciplinary one. And at the same time, I must thank him for inviting me. Well, since this is a multidisciplinary conference, and I believe all the doctors are coming from different stratas of life and from different disciplines, so I chose the subject about rising an awareness of cervical cancer and its principle. And I promised that I would keep to the very basics of gynecology. Well, just to recapitulate, I would tell you that as we all know, that as we all learned, that this was the uterus on the cross section, and this is the lining which we are concerned about. The basic thing is it is lined by a columnar epithelium, and the vagina is lined by the squamous epithelium. We are concerned about the stratified squamocolumnar junction, which is the seat of all the pre-malignant lesions and the malignant ones as well. Just to impress upon you the burden of this disease, I must tell you that 5 lakh women are diagnosed with cervical cancer each year, and 2,70,000 women die because of this disease in each year. In India, the scenario is equally bad. 1,32,000 women are diagnosed with cervical cancer each year, and 74,000 women die because of this disease. And to put it in another basic way, the deaths from cervical cancer is 200 women every day, 8 women die every hour, and every 7 minutes, 1 woman dies of this disease. The human papilloma virus is the known cause of this cervical cancer, and there are more than 100 types of HPV known till date, of which 15 types are cancer, which causes cancers are known as oncogenic or high-risk varieties. They are 16, 18, 45, 31, 33, and 35. Well, this is how it looks when you look at, through an electron microscope, and this is the human papilloma virus under an electron microscope. As I said, there are 100 types, and of these 30 types are transmitted by genital skin-to-skin infection contact, and of which 15 types causes oncogenic cancers. 90% of cervical cancers are caused by 5 types of HPV, which are 16, which is the most common, 18, 31, 33, and 45. Well, how does it get to us? It is transmitted both to men and women through sexual intercourse and sexual contact. Abstinence is a way to prevent it, but not feasible. Regular condom use can help decrease the spread of HPV as well as other STDs. The basic thing is that a woman in her life would acquire at some point of time HPV infection after consuming intercourse, after resuming intercourse. But the good thing is majority of this infection will clear of its own because of our body's immunity. But a few will persist and develop precancerous lesions and in fact cancer over a period of time. If we go back to the basics, this is the basement membrane of the squamocolumnar junction. These are the basal, parabasal, intermediate, and squamous cells. After intercourse, some point of time, the patient will develop human papillomavirus infection. As I said, 80% will clear of this infection, and 20% will have this infection as a persisting infection, and this can progress to CIN1, that is cervical intraepithelial neoplasia 1, 2, and 3, which are all pre-malignant. I wanted to highlight this slide because I wanted to say that cancer of cervix is preventable, because if we do a regular pap smear, then we could diagnose the patients in this area, and in this area the treatment is very simple, and the patient could be cured without letting them go or progress to invasive cancer of the cervix. Spontaneous regression also occurs in SIN1, that is cervical intraepithelial neoplasia 1, and these may progress in 20% to invasive cancer and 5% to cancer. And the bad thing is that patients who do not have a regular pap smear often come to our OPD with such types of lesions and vaginal bleeding, postcoital bleeding, and then eventually when we do a biopsy, we get an invasive cancer, which is, has a bad prognosis. Cervical cancer is basically squamous cell carcinoma and cervical adenocarcinoma, which is 25% and 75% is the more common variety. But the main thing about adenocarcinoma is that it is on the rise, and especially it is difficult to detect by screening methods and have a poor survival rate. As I said earlier, that all women after consummation of marriage or having intercourse, 50 to 80% of sexually active women will acquire an HPV infection at some point of their life. This is true for everyone. Up to 50% of these will be with an oncogenic human papillomavirus type, and majority will clear. Young women are at greater risk of HPV infection. Women will continue to acquire new human papillomavirus infections regardless of previous or prior infection with the same or different type of human papillomavirus. Therefore, one infection with HPV doesn't give you any protection against another HPV infection in life. These are the factors like poor socioeconomic class, first age of coitus early, multiple sexual partners, multiparity, human papillomavirus, poor genital hygiene, racial variety, seminal fluid smoking, and so on. And the important thing about cervical cancer is that it is preceded by a stage of epithelial abnormality which is precancerous, and that lasts for usually 1 to 10 years of duration. So the aim of us will be to detect the patients in this 1 to 10 years and cure them and prevent the occurrence of invasive cancer of the cervix. So who are the women who are at risk of cervical cancer? Obviously those who do not undergo a regular pap test, and other women who are immunocompromised, like on steroid medications, transplanted organs, HIV, and who smoke. There are certain signs and symptoms which you must be aware of and come to your doctor if these occur, like vaginal bleeding. Menstrual bleeding is longer and heavier than usual, bleeding after menopause or increased vaginal discharge, bleeding following intercourse or pelvic exam, and pain during intercourse. And how do you lower the risk of HPV? Especially, you must have a cervical cancer vaccine between the age of 9 and 26. However, this age has been extended to 40. Delay the onset of sexual activity. You must know your sexual partner. Do not smoke. Maintain a healthy diet and lifestyle, and practice safe sex. There are two types of prevention of cervical cancer at present. One is primary prevention, which is by vaccination, and another is secondary prevention by screening for early detection, diagnosis, and treatment of HPV infection. Vaccination provides primary prevention against cervical HPV infection, and HPV vaccines containing the most important oncogenic types, that is 16 and 18, will also provide cross protection against other HPV types, and therefore will provide a 90% coverage against squamous cell cancers and 95% coverage against cervical adenocarcinomas. But one thing you must keep in mind, that because vaccination does not protect against all oncogenic types of HPV, therefore screening must go on. Even if you have vaccine, screening must go on. Cervical cancer screening has greatly reduced the morbidity and mortality, but has its own limitations. It does not prevent infection or development of precursor of cervical cancer. Lesions which progress quickly may not be detected, and early stages of adenocarcinoma are difficult to detect. Cervical cancer screening is not widely available in our country. That is the saddest part, though it is not very high-tech sort of investigation. Cervical cancer screening in India is poor, is very low among rich as well as poor uniformly. Like 6% and 4% of these community go for a cervical pap smear screening yearly, though WHO recommends cervical cancer screening for all women after 30 years of age. Fortunately, some of the women with pre-malignant lesions, though unknowingly, come to our OPDs for a regular pap smear test, and we can detect these women in a precancerous type of lesions and can treat these lesions effectively and with very simple procedures like laser vaporization, long loop electrosurgical procedures, and thereby prevent invasive cancer in these women. So pap smear is very essential part of cervical screening. It is a very simple test whereby the doctor detects any abnormal changes of cervical pathology and thereby prevents or detects the cervical intraepithelial neoplasia or other dysplastic lesions and treat them and therefore prevent cancer in the patients. Speculum is usually inserted, and from the cervical lip, a cytobrush is used to scrape the cells, and these cells are dipped in absolute alcohol and then smeared on a glass slide to be looked through a microscope. The reports could be normal, could be infective and abnormal. Mild abnormality, you repeat the smear. Persistent or moderate abnormality, you go for a colposcopic directed biopsy, and thereby you have a very simple treatment and follow-up. The question which you have will be, when should I get a pap smear done? Well, you should start getting pap smear 3 years after the onset of sexual intercourse, but no later than 21 years of age, and it should go on up to the age of 70 years. It is said that if there is no abnormal pap smear reports during the last 10 years, then you can stop pap smear at the age of 70. Screening after hysterectomy for benign causes do not require any pap smear test, and WHO recommends to start after 30 years. Vaccination, as I said, provides primary prevention against cervical HPV infection, and it provides protection against 16, 18, 35, 31, and 45. So cervical cancer vaccine is available in our country. We have two types of vaccine. One is Cervarix and one is Gardasil. So I just wanted to highlight this slide because many of us are not aware of this vaccine, and most of our children would be benefited if we advise them Cervarix or Gardasil as protection against cervical cancer. When should our children get vaccinated? The FDA has recommended that the following groups of women get vaccinated. They should start as early as 9, but 11, 12 years is okay. And this vaccination actually, it depends on the cultural society where we belong to. It is basically depends on when the sexual intercourse activity is going to start. So that is why they have devised the age of 11 to 12 years. It is in the Western world. We can start at around 13. We never know when they go on. And then this can be extended to adult women from 13 to 26, but 26 has been extended to the age of 40. Women who are married can also have this vaccine, but then the HPV exposure in these women is already there. Therefore, the benefit of vaccine in this age group is less than the younger age group. You must discuss this with the patient before giving this vaccine. The IAP recommendation of the dosage schedule is 3 doses. One is 0, 1, and 6 months for Cervarix, and 0, 2, and 6 months for Gardasil. However, 3 doses are required. Minimum side effects may occur as with other vaccines. These could be redness and soreness where the shot is given. Headaches could occur. During pregnancy, we do not advise this vaccine, and when we give the vaccine, we expect the woman not to become pregnant within 6 months. So, to sum up, the cervical cancer is #1 cause of cancer-related deaths in India. Screening until recently was the only way to detect abnormalities and prevent cervical cancer. Although effective, screening has its limitations: reliability, cost, and compliance. Vaccination offers a new alternative in preventing an infection that may lead to cervical cancer, and vaccination along with screening could further reduce the burden of cervical cancer. We have a pap smear clinic in BR Singh OPD at 2 o'clock every Monday, and I suggest you could also start a pap smear clinic in your hospital, which is just basically doesn't need any high-tech instruments, but is very beneficial. And at the end, I must thank the organizer for giving me this excellent opportunity to speak in front of this august gathering. Thank you very much.
Thank you, Dr. Basu.